Markus Lingman ráðgjafi sænskra stjórnvalda í innleiðingu þeirra á gagnadrifinni heilbrigðisþjónustu og þar sem Markus mun flytja erindi sitt á ensku ætla ég að kynna hann á ensku örstutt. Markus Lingman has a background as a senior physician and has spent several years in healthcare management along with his professorship of medicine. Today, he is a Chief Strategy Officer of Region Halland in Sweden and the national government representative in the Swedish Scientific Council for Medicine and Health. Markus Lingman is affiliated to Halmstad and Gothenburg University and Karolinska Institutet. Markus, the floor is yours.
Thank you. And you can also hear me. That's perfect. Thank you for inviting me to this wonderful island. I had a very nice run around Reykjavik yesterday to see the environment for the short stay I have. And I realized I need to come back soon because there's so much more to see. So today I'm speaking on the subject of what we nowadays call information-driven care. So what is that? That is basically how to utilize as much of the information, the wealth of information stored as data as we can in order to improve healthcare as an ecosystem on the individual level, patient level, but also on the systems level. And I will tell a short story of the region where I'm the Chief Strategy Officer, called Region Halland. It's one of Sweden's 21 regions, but it's kind of a vanguard area in Sweden, inspiring other parts of Sweden in how to work around this subject. And interestingly, it's quite similar to Iceland, actually. It has basically the same number of hospitals, grossly the same number of inhabitants, and it has its own government and so forth, like all the other 20 regions in Sweden. And it's situated around the Gothenburg area in the south. So what's information-driven care? Well, it's basically, the notion is simple. Using all the data that we have, we digitalized early on, and now we stored the data mostly, but we didn't use it enough. So making use, leveraging on all the data that we have in storage and producing all the time, every day in healthcare, and turn it into information, something that we can as humans relate to create new insights that we can act upon or alter our behavior, because that's, as the ministry said, that's the value, where the value is created. When we do something differently, that creates new value for patients. So that's the simple part, the notion. How do you do this in real life? Well, you need the data. And that's not all that easy. Is this a pointer? Hope so. No. So on your left here, we have 400 software systems running in healthcare every day in our region. The electronic health record is one of them, but we also have the lab software and the radiology software, the social welfare software. We have so many software producing data. And the interesting thing is that they produce data around individuals. But we don't organize the data around individuals traditionally. We organize it around the subject, finance, economy, quality, whatever subject you're into. We also arrange it according to the organization. So this is my department data. This is our hospital data, whatever kind of silo you're part of. So we don't have a patient-centered way or individually-centered way of managing information in healthcare traditionally. So we addressed this problem, and we started importing the data virtually or physically into a warehouse from where we use data from many different purposes with dashboards. Simple as that. That's traditional business intelligence. Nothing fancy about that. But when you have the data, you can create new insights on the systems level, how the patients fare through the system, and what each silo is actually doing. But we also use the sandbox. So we relay the data from the warehouse to sandbox. And why is that? Well, that's because we need to play around with data, use it in much more dynamic way than we can do in the traditional environment where we need to do reporting and all those like very structured way of handling data. So in the sandbox, same data, but we can play around with it, again, from very many different sources. But as you can see here, we also invested in something called GPUs. So those are AI computers, so that we can crunch the data on-prem and create new insights based on very complicated patterns. And we also do it for with research, so we close the gap between research insights and healthcare delivery, because we do research on the same data that we produce when we deliver data. Or deliver healthcare, sorry. And why is this increasingly important? Well, because, as the minister said, the challenges are not within the traditional simplistic way of delivering data. So if you have a otitis down on your left, you go to the GP office, for example, you get a treatment or not, but anyway, it passes, and that's the only encounter in that silo. Then we have on your bottom right for example, cancer patients, people that are struck with cancer. And they follow a path, like we do one thing at a time in a certain sequence. Intellectually super simple. And they pass many silos, many departments, and so forth. Then we have the chronic patients up on your left. They come and go for the same things, and we keep track of them over time. But those are not the problematic challenges. The problematic challenge is the top right. The patients that are everywhere and nowhere at the same time, in between the silos, in several silos at the same time. So those are the unhappy people. Those are the ones where that fare the worst, that get the worst treatment, and sadly, that is the most rapidly increasing group of patients. So those are multimorbid, often elderly people needing a lot of care. And we try to deliver care for those in a system that is structured in this way. How is this even possible? I'm amazed that we can't deliver care at all for those patients in the way we traditionally do. This is not an Icelandic challenge, it's not a Swedish challenge, it's a global challenge. Because it used to be the case that we didn't have the opportunity to share information. So why build a system that information is continuously shared? And we specialize, and we want to confine ourselves in our specialist department with our peers and do the best we can for the patient we meet that day. But again, everyone is going to work to do their very best. But on the total, it doesn't deliver the way it could. So it's becoming even more challenging, but more also opportunities in this market. And I said last night at the dinner that I think Iceland can be the global trailblazer in healthcare development. because you have so many opportunities that are difficult to handle in other settings that are even more complex than the Icelandic setting. So around the traditional brick wall, hospital, GP office, healthcare, now an ecosystem of providers are appearing. Where are you, Simander? Up there. So you're around here somewhere, in one of those bubbles, creating new ideas on how to deliver care, but how do you make that part of the ecosystem? Because this could be even more fragmenting than the traditional healthcare system that we work in. And interestingly, all of these new providers, they didn't make the analog journey. They are digital by default. So, and if you're digital, that means information is data. So again, information-driven care. And my idea is that information and data can actually be the glue that makes this stick together instead of fragmenting even more than could have been the case. If we do this in a patient-centered way. So in our data warehouses, which could be virtual or physical, don't care actually, we organize data based on the patient, not the subject, not the organization, but the individual. So in the middle here, you see an Icelandic patient. It's obvious, isn't it? Those green bubbles are things that happen to as Icelandic or Swedish or American patients. Different bubbles, different encounters. Those could be an ED encounter, an ambulance travel, or whatever. But to all those, we connect whatever happens during that encounter. Clinical information, but also financial information, and you can also even connect GeoID if you want to know where it took place. So getting a more holistic picture of the individual based on data, so we can start building efficient, glued together patient trajectories or journeys, going beyond fragmented healthcare, using data and information as the glue. So today, we can follow patients through the system and see if we do something here, financially, it alters something that affects a later stage. Have you ever heard sayings like, if they would have, I would have it better. If they do something else, everything would be very good. Or no, that's not an Icelandic thing. It's definitely a Swedish thing, though. So if primary care could do something better, we wouldn't have those huge problems in the hospital. And now they're all coming to the emergency department because the opening hours are not good enough in primary care, blah, blah, blah. Nobody actually knows. But if you are able to trace those patients, what's actually happening to them, and what investments we're making, then you can have a much more constructive discussion on that topic based on facts. And also, together with people at Harvard, in this case Harvard Business School, we developed a way of also describing the resource utilization across the journeys so that we can measure if we invest here in this part of the trajectory, maybe we can save money back here at a later stage. So front-loading investments, but not like in a this is probably a good way, but in a measured and calculated way. And the latest addition to these capabilities is actually to understand also the carbon dioxide emissions for every encounter along the way. So now we can understand the quality of care, the resource utilization in care, but also the climate impact of care on the individual level across the system. All right? Which means that we can start in a qualified way trying to understand how can we break the chains of care by decreasing the need for escalation. So going from your left, just Simonder's mother, probably home, having a headache, whatever, and she goes to home care, and they can't resolve it, so they call telecare, or it refers to the general practitioner. Every step here is an escalation. And if we can meet the need of that woman earlier, then a few % of this part of the trajectory will not appear. Can you understand the lever of that investment? The resource utilization intensity, different word, can we say that together again? So is incredibly high in this part of the patient journey. And if you can even reduce that by 1, 2, 3%, you can finance a lot of stuff early on, okay? But you need to do this in a fact-based way. And we do it by dashboarding, as I said. So these are dashboards where we continuously follow groups of patients. We could do it from a central view on the individual level. We don't do that because of integrity reasons, but the clinician, if on the floor, can do it on the individual level if there's a patient relation. But on senior level, we can monitor the healthcare system and the trajectories and the patient groups going through it to optimize the healthcare structure. And this is what a very simple dashboard could look like. There are many of them across the world, probably also in Iceland. This is congestive heart failure in Swedish, where the cardiologist can follow in detail, are we doing what we should as a system for these patients? So this is primary care data, this is hospital data, this is ambulance data, this is call center data, whatever data. And we use it to trace actually patients group through the healthcare system. So we know where they are. Do you know where your patients are? It's really difficult to know where they are if you don't have this overview of it all. And we also use it in a more, the data in a more dynamic way. And we call it actually jam sessions. It's from jazz. So this is where we gather from different professionalities, like this could be a legal team member, this could be an economist, health economist, clinicians, whomever needs to be in the room in order to think through a question in real time using data in real time. I'm sure you've been in meetings where the result is we need to understand this more. Let's start an investigation or inquiry and meet again in 1 month. In this room is like a conclave of the Pope. So no one can leave the room before we're finished. Okay? Incredibly efficient, because everyone wants to leave the room before lunch. So we use the data in real time. We have data scientists in there. We have business intelligence people providing the data in real time. We need to know this. How does this affect this? Well, bring up the data on the screens and we'll discuss it. In fact, and then we leave the room with an idea on how to go forward. So what does AI have to do with all this? Well, we digitalized early 2000. We started using what I predominantly showed you now, kind of Excel data. Those are tabular data, traditional data in square sheets. But we're not there anymore. So data are dynamic, but they're also unstructured. So I would say maybe 80% of the information about patients are in unstructured data. They don't fit in Excel sheets or traditional BI tools. So we embraced AI. AI is mathematics. It's built to work with unstructured, nonlinear data, which means real life. And we use it for example, understanding why people actually come to the emergency department. There are so many ideas on why people go to the emergency department, and so many wrong ideas, because it's really hard to understand, actually, why. So this is an explainable AI model, where we built a model to crunch thousands of variables, thousands of features, aspects of patients, to understand how, if we can predict if he or her would come to the emergency department and why. We also use it, for example, to understand why people come back to the hospital once we discharge them. We don't want them to need to come back. And why is this important? Well, because then we can start addressing the root cause of these quality impairments. All right? So this is information or data-driven healthcare development. Can you do this for prevention? We have the pink month or whatever, yeah? So it means that half of the people in this room or so should get a mammogram. Go to the radiology and get the breast x-rayed. How many people will benefit from that x-ray? So 1 in 200 women actually has a difference out of that x-ray. The challenge is that we don't know beforehand who that will be, so we need to x-ray many. But we could direct, if we wish, the prevention, but also the screening much better than that if we use all the data we have. But that's more of an ethical issue. Is that something we want? That's not a medical issue, in my opinion. So that's why politicians need to be in this, to understand how do we protect integrity and at the same time increase efficiency? Ethical, important questions. What we did here was that we used data in a research project to understand if patients would come to the psychiatric acute care 1 year before they actually went there, and we could do that with 94% accuracy. Which in our organization has meant that we didn't need to increase the size of the hospitals. We have an increasing population, but if we would have just done nothing, working the same way as we did always, we would have needed over 668 inpatient bed related to the 400 we actually have today. Can you imagine that cost efficiency improvement? We could not even reach 668 because we have no staff for that anyway. So one of my messages is that this is not an IT issue, nor is it a medical issue or a management issue. It's everything at once. That makes it very interesting and very complicated. But we need to work together across knowledge domains. And we need to work with the same goal. The financial people need to know what the goal is. The management and the clinicians need to know what the goal is, so we work together. What we're doing now is to implement a system, this is called Alma, so that we can act individually on the insights from the information that we crunch, to reduce the cognitive load of the healthcare staff, because they are really stressed, or we are really stressed. So if the patient comes to the emergency department or the outpatient clinic, and we know that she should have taken her blood pressure, but it has not been done, we push that information to the situation. So the clinician doesn't need to keep track of everything that should be thought of for that patient. We're also introducing something called ambient scribes, which is AI listening to the patient-doctor conversation and automatically generating the electronic health record notes that are tweaked and finalized before the end of the meeting. And we try to include also patient-centered or patient-generated data in this ecosystem so that we can relate the asthma tuner data, wherever that is there, to everything else that's being done in healthcare to that asthma patient, to get a holistic picture of what's actually happening with the complex individual. Those are just a few thoughts that I want to give you. You can just skim through them super rapidly. But what I want to stress is the second one from the bottom. It enables joint venture innovation with private equities or private investors if you start early within the frames of the law. But you need to start early at the stage of the idea. So just to wrap up, what are we doing now going forward together? You stressed personalized medicine, precision medicine. Precision medicine or personalized medicine requires data. So you cannot have personalized medicine if you don't have a holistic view of the individual. And that's where precision medicine and AI merge, because it's so much data, so complicated data, that you need the toolbox to be able to embrace and handle that complexity. So now we are merging what's called multimodal data. Again, new word, say that together. Multimodal data is tabular data, traditional old school data, with genetic data. This is where Iceland comes in the picture. And imaging data. And clinical data. When we meet patients, information about that meeting. We merge those to get the holistic, multimodal picture of the patient so that we can increase accuracy in what we do. Not guidelines, but individual trajectories of patients. That's the precision. Okay? And we're also embracing the transition from tabular data to the other 80% of the information that exists. And that's where language models, transformer, foundation models, many names, come in to the picture. And that's where Iceland could either develop new language models in Icelandic or work with us in the Nordics to develop them together and fine-tune it towards Icelandic. There are several ways forward, but this is where things are going right now. Thank you.